Now coming to the surgical treatment. Once the antimicrobial therapy has started and the patient starts to respond to the therapy, and provided there is no multi-drug resistant or all drug resistant tuberculosis, then to cater for the local inflammation and local arthritis, we can go for certain surgical procedure as well. For example, if it's isolated synovial hypertrophy and generalized synovitis, we can also go for some form of orthotomy, go for lavage and proper cleaning of the knee joint, and provided if there is no massive arthritis. Although usually orthotomy is nowadays not preferred until unless there is acute arthritis or bacterial infection. But previously it could have been done, because nowadays orthotomy has been mainly replaced by arthroscopy, and arthroscopic synovectomy as well as lavage and biopsy can all be taken by use of mini ports and simple incisions, instead of going for a big incision and open up the whole joint and do the same thing. Now arthroscopy has sort of facilitated that the treatment, and in a way we can make small incisions and go in, do all the process which we were doing by the use of orthotomy, and we can also get the biopsy done to confirm our diagnosis as well. Then if it has progressed to a point where it had become a point called as there is massive arthritis, there is cavitation, and the joint may have started to ankylose, then we have practically two options. One is to go for orthodesis. That is, this is how orthodesis, or then is to go for total knee replacements. Once the patient has gone through the synovectomy and synovial biopsy has been taken, we can initially, as the antimicrobial therapy is going on, we can start the post-operative rehab therapy post surgery as well, and this usually involves strengthening of the quadriceps muscles, giving nighttime sprints, bed rest, as well as starting exercises so that patient can bear weight. But all this goes along with the triple drug therapy, that is the isoniazid, rifampicin, ethambutol and pyrazinamide has to go on. In some countries the regime may be different, because isoniazid, rifampicin is given in all cases. Ethambutol and pyrazinamide sometimes is given for initially, and sometimes it's not discontinued after some time, and in other countries it's actually continued for a little longer time. Then you have to give them traction as well at times, because it actually, the more the joints are apart, it actually soothes and it decreases the edema pain over there. And then you may have to go for intermediate active and assisted exercises as well, because rehab is important post surgery. And so that patients, as the tuberculosis of the patient starts to get cured, patient is able to start walking along with it as well. And now the antimicrobial therapy is in place, the patient will have less sort of an edema and complications, and arthritis will not progress the way it was progressing previously. Then we can also use a suitable brace for ambulation as well. The point is, if the disease is at initial stages, we can simply do the synovectomy, we can do the lavage and actually get rid of the local burden of the disease, and then rehabilitate the patient so that patient starts walking again, along with the continuation of the antimicrobial therapy. But if it has progressed beyond that point, then we have other surgical options as well, and that includes, one of the options is orthodesis, although that's also kind of an old method and usually rarely done. But for example, this can be an option, because there has been case reports in literature as well, in which there was total knee replacement was done, later it got infected, it was done for the second time, but it got infected again, and at times the bone loss is so massive that you don't have much of an option but to just go for orthodesis, because once the orthodesis joint will not move, but at least will remain free of infection. Therefore, then again, this is to decide between orthodesis versus total knee replacement. Total knee replacement is much better option, but at times you are so clinically hampered, because this is kind of a latent infection. It will remain indolent and latent for a long period of time and get reactivated, and once it gets reactivated, it may infect all the metal which is in place for the TKR as well. Then with the advent of new joint replacement surgeries, arthroplasty is a very good option for end-stage arthritis of the knee joint. And nowadays, usually end-stage arthritis, whether it's secondary rheumatoid arthritis, whether it's tuberculosis, or even whether due to any other disease, eventually goes towards the knee replacements, and it has very good results as well. But the problem with the tuberculosis is actually that it can reinfect, and latent infection get reactivation, and then it may lead to reinfection of the metal prosthesis as well. Therefore, at times risky, but yes, you have to tell the patient straight away that yes, I'm doing this, I'm replacing your knee, but this infection can come back and problems can be much worse than it is now. We have discussed briefly the tuberculous arthritis and how it is actually a diagnostic dilemma. At times, the patient may have history which may be vague as well. There may be no symptomatic or systemic signs as well, and there may be no extrapulmonary history of tuberculosis or even negative family history. But whenever you are seeing a patient with monoarticular arthritis, you have to rule out previous history of tuberculosis, previous family history. Make it sure you get all the examination done and rule out other causes of swelling and pain in limb. And then once you go for the lab workup, you have to go for Montu test, quantiferon PCR gold test, as well as Zn staining, and biopsy is mandatory to confirm your diagnosis or refute it. And once we have done all the x-rays, lab workup, and as well as confirmed our diagnosis of the tuberculosis, then first thing first that we start with antimicrobial therapy. And then, because antimicrobial therapy is in place, that will look after the systemic disease. To cater for the local disease, this may involve synovectomy, splintage, rehabilitation, or even total knee replacement. And if things get too worse or there's a reinfection of the prosthesis, we may have to eventually go for orthodesis of the knee joint. Thank you very much. Keep watching sqadia.com.